Good morning and welcome. My name is Mark Southern. I am the Commercial Director at WPA, and welcome today to Heart Health and Beyond. We are really lucky to have Christian Muller, who is a Strategy Manager at the Cleveland Clinic in London, and we're also hoping to have Professor Bernard Prendergast, who is the Chair of Cardiology at the Cleveland Clinic in London. And they're going to talk to us a little bit about the predicted surge in heart issues that we may experience post-lockdown. Now, as ever, some things always don't go to plan, and Professor Prendergast has been slightly delayed in surgery. He is on his way. However, we thought it'd be quite good fun just to start this morning's broadcast by just doing a couple of polls. So if we can bring the first poll up, please, just to get us all in the mood. So if you can answer these as quickly as you can, do you foresee a surge in demand for treatment as the UK unlocks from the pandemic? 3 simple answers: yes, no, or don't know. We won't be voting because we'll be obviously tilting the results and how we feel, but just take a quick minute there just to provide your answer. That'd be really useful. Here's the results. Yeah, 90%, 94%. Oh, fantastic. That's pretty unanimous. And only 4% don't know. Let's move on to the second one now, please, if we can. Second poll. Do you think that the advances in surgical methods such as robotics will bring down the cost of treatment? Again, you've got yes, no, and don't know. I'll just give you 30 seconds to answer, and we'll bring the results up again. Okay, much more split this time. 51% saying no, and 33% saying yes, and 16% saying don't know. Perhaps that's a question we shall ask both Christian and Bernard later on. Let's go for the third one now. How healthy do you think employees at your company are, with 1 being very unhealthy and 5 being very healthy? So that's 1 being very unhealthy and 5 being very healthy. I think we've all sat on the fence there and gone for number 3, so sat right in the middle of it. With number 4 being 33%. Again, very interesting, and again, maybe you'll change your opinion after we see the presentation today. I think we've got 1 more poll, which we will do. Let's see how the 4th one looks like, please. Is your company actively encouraging improving the health of employees? Yes, no, or don't know. And again, we'll just take 30 seconds to answer that, and then we'll bring the results up when we're ready. 74% yes, that's fantastic to see, and 19% no. Well, that's been really interesting. Let's drop that poll off. If nothing else, it's given us an understanding how the system works, and we'll hopefully find that easy to use. So how today's going to work, so Professor Prendergast and Christian are going to speak for around about 20 minutes, and then we've got a bit of time for questions and answers afterwards. So please ask your questions as we go through the presentation, and you click on the question tab in the window that you see on the screen now. If the window isn't there, there's that little kind of white arrow on the red background. Just click on that and it should appear. Okay, so that's how the question piece works. So to start off with, and without delaying any further, I'm going to hand over to Christian, who's going to take us through the start of the presentation, and then hopefully Professor Prendergast will join us at the appropriate point. Thank you so much, Christian.
Thanks, Mark, and welcome everyone to Heart Health Beyond Lockdown. I'm sorry you've got me for the start of the presentation rather than Professor Prendergast. I think it's one of the double-edged swords of working with one of the leading cardiologists, is that effectively he's had a patient emergency, and I've had to see that patient rather than the presentation. So today I'm going to take you through the beginning of the presentation, talk you through the situation that we currently have with COVID-19 and how that has impacted cardiology and cardiac surgery. We'll then talk a little bit about how to keep clear of cardiologists, how to keep clear of Bernard Prendergast, and how not to have your employees visit one of our hospitals. And then a glimpse of the near future and the kind of new technology and new techniques that we're seeing in the world of cardiac surgery and cardiology. So just running on to our first slide. COVID-19 and cardiovascular disease. The way Professor Prendergast has described this is as twin pandemics. We're all very aware of the pandemic, COVID-19, and the impact that has had on the UK. There is a greater impact that I think is hidden at the moment that we're not seeing in the stats or in the NHS waiting lists, which is that patients aren't attending hospitals. We already know that 5.1 million people die each year from cardiovascular disease in Europe, and that hasn't gone away. Cardiovascular disease is responsible for 31% of deaths worldwide. But what we have seen this year is that patients are not willing to attend their GPs for chest pains, breathlessness, whatever else may be the symptoms. And there is a building cohort of patients in the background of COVID-19 who we are due to see coming into sort of the end of this year. We expect those waiting lists to start to expand, and this huge cohort of patients who haven't been seen during COVID to suddenly surface. I think this year has been. Hi, Bernard. Good to have you on board. I'll let you take this away.
You were doing a wonderful job with that slide. I think I might just fade into the audience and let you give the entire presentation. So good morning, everybody, and apologies for being delayed. I interview students for medical school, and one of the best answers I ever heard to the question, why do you want to be a doctor, was because I don't want to know what's going to happen at work today. And of course, despite the best laid plans for this webinar and intense preparation, I am a little bit delayed because of clinical events beyond my control. So apologies for that. But also thank you very much to Christian for providing a very seamless introduction and keeping everything on track. So let's have the next slide, please, Christian. So Christian has emphasized that we were already dealing with an epidemic of cardiovascular disease, but of course in the last year, our attention has been distracted elsewhere by the circumstances of COVID-19. And these have, of course, been extraordinary times for everybody, as exemplified by these photographs that I took of central London last March, as I made my way home from an NHS session at St. Thomas's Hospital, where I also work. Challenging times for doctors, challenging times for the great public, and challenging times for families and individuals in communities up and down the land. Next slide. And when we think about the impact of COVID-19 and the heart, we need to think about two separate concepts. The first is the way in which COVID-19 can exert direct pathological effects on the heart itself. And of course, we were learning step by step when this came upon our shores last year, but we now understand the condition more considerably, recognizing that it can affect the heart muscle, it can affect the heart arteries, and it can also affect the lungs, which of course have major interaction with the function of the heart. And in one particular survey where ultrasound scans of the heart were performed, echocardiography, in over 1,000 patients, you can see that the heart was affected in over 50% of patients presenting with COVID. And that's, of course, before we even begin to think about and quantitate the longer term consequences of COVID on heart and lung function. And the so-called long COVID syndrome is yet to be fully evaluated and understood by doctors and by the public. Next slide. A particular concern of mine, however, has been the fact that the indirect impact of the virus has been firstly on health-seeking behaviour of individuals, whereby in the spring and summer of last year, there was a dramatic reduction in the number of patients presenting to ambulance services by 999 calls, and then coming into hospital 2 or 3 days later, when it was much too late for the doctors to be able to help the patient, with late presentations of heart attack, of stroke, of infections involving the heart, and the consequences of heart valve disease. Secondarily, because resources within hospitals up and down the land were focused on the care of COVID patients, and because intensive care units were full of patients on ventilators, it was not possible to deliver normal programs of work. And if you could animate the slide now, Christian, you can see here, for example, the impact on heart surgery, surgical aortic valve replacement, SAVR, or coronary artery bypass surgery, CABG. Numbers fell dramatically by up to 80%. Next slide. And of course, the secondary consequence of that is that waiting lists have grown inexorably, not only in heart disease as illustrated here, but perhaps more consequentially upon services like orthopedics, ophthalmology, gynecology, rheumatology, you name it. Because whilst we have been able to continue some of our heart activity throughout the last year, there are many services that have stood literally still for the last 12 months with no activity and waiting lists growing exponentially. And as this senior NHS executive has been quoted, it will take a number of years to recover. My own conservative projection is that it will be at least 3 or 5 years until we get back to where we began. And do remember, of course, that the NHS was struggling before COVID appeared. So it is rather a gloomy landscape. Next slide. Now, if we think about your employees and if we think about your clients, we need to focus on individuals and work out how we keep them out of the hands of cardiologists and how we prevent them from developing heart disease in the first place. This list of so-called vascular risk factors is well known to most of you. And some of these conditions are avoidable, and some of these circumstances, these lifestyle options, as it were, can be addressed, both at primary care level as well as in the hospital setting. Next slide. But we do need to remember that even with the best preventative treatment, heart disease can still strike, as illustrated by this case study. A patient of mine that I looked after approximately 4 years ago, a 66-year-old man working in the city, fit and healthy, running, jogging and skiing on a regular basis, who had never smoked, who had recognized his family history of blood pressure and cholesterol trouble, had consulted with his doctor and was taking medication to regulate his blood pressure and his cholesterol, and who has had no other medical problems in the past. Next slide. Lo and behold, at midnight one Saturday night, he developed severe chest pain and collapsed in cardiac arrest at home in central London. He was brought urgently to St. Thomas's Hospital, where I was on call, and immediate coronary angiography within minutes of arrival demonstrated in the left-hand panel a normal right coronary artery, but in the middle panel, a missing major coronary artery identified by the yellow arrows. And thanks to the miracles of modern medicine and a bit of luck on my part, within 5 minutes, we were able to open that artery, put in a coronary stent, and restore blood flow and open the blocked artery, as illustrated in the right-hand panel. And I'm pleased and proud to tell you that 5 years later, this man is still fit and active. He survived the experience, and if it weren't for COVID, he would have been skiing this winter. Next slide. Now, employers have a responsibility to look after their employees, as you do for their clients. And there are major pieces of lifestyle advice that we can provide. Firstly, for individuals during the period of COVID, as listed on this slide, by means of a healthy diet and a sleep pattern, maintaining social networks with the help of virtual technology if needed, digesting information sensibly about the COVID outbreak in order to manage some of the psychological burden that we all face, to work carefully to maintain a sensible balance between work and home, because I can speak from experience, working from home means that work is always with you, and it's always very tempting to dip into email or to stay ahead of your work stream, and that's a strategy that we all need to avoid. We also need to be careful that we don't lean excessively heavily on alcohol or other drugs to sustain us. And we also understand that regular exercise is good not only for the heart, but also for the mind. Next slide. Beyond COVID, and I'm not sure when, but there is a future beyond COVID, it's important that individuals in young, middle and older age maintain an awareness of their cardiovascular risk by means of addressing their risk factors supported by their primary care physicians, undergoing annual medicals, participating in exercise and healthy living, often supported by their employers, being aware of their heart health through seminars such as this, by maintaining access to cardiac specialists, be they in primary or secondary care. And finally, as I was hinting earlier, not to put symptoms of heart disease down to the potential effects of COVID, while also being aware that COVID may cause long-term health consequences, and both heart disease and COVID need to be addressed in conjunction. Next slide. Now, of course, cardiovascular healthcare is a rapidly developing field, and I'm pleased to say that despite COVID, we are continuing to make progress. All of the measures that I've indicated to you historically have been based upon what you might call herd medicine, looking after the population, screening the population, and applying treatment to all of them when we perceive them to be at risk. And the field of precision medicine is enabling us to see a future vision where we will be able to identify the most at-risk patients at the earliest stage by means of genetic technologies and genetic fingerprinting. Rather like we can now predict those patients who are most likely to develop cancer, we will in the future be able to predict those who are at risk of heart attack and stroke, for example. And we will instigate treatment for those patients much earlier than we do at the moment. And we will also be able to select the drugs that work for them as an individual, rather than giving them the whole cookbook, which is our current strategy. We already have and will have improved versions of non-invasive imaging, allowing us to see the heart from the outside, as illustrated by this three-dimensional CT scan on the right-hand panel of this slide. And we will also move into new modalities of healthcare delivery, whereby the traditional model of the patient coming to the clinic or the hospital and sitting and waiting for their physician to be ready will be turned upside down, and the doctor will call the patient for a virtual consultation when the patient is ready. The patient will have access to wearable technologies, allowing their physiological information to be transmitted to the doctor by digital means. And of course, this opens up the whole concept of global healthcare. So, for example, yesterday I was speaking to a colleague in India who's very keen to network access for his patients in Mumbai to specialists in London and Los Angeles, allowing them access to world-leading opinions and world-class treatment and technologies, not necessarily in their home city. Next slide. We also have innovations in treatment. We have access to keyhole options for many diseases now, as illustrated here by means of the array of technologies available for keyhole treatment of heart valve disease, a field where I have a particular interest and speciality. Next slide. These interventions themselves are supported by and enabled by advances in the imaging that I already mentioned. And these state-of-the-art imaging technologies illustrated here allow us to see the heart in advance of our procedure. They allow us to simulate the implantation of devices according to individual patient anatomy, and they allow us to fuse the pre-procedural images with the real-time procedural images, allowing accuracy of the procedure's execution. And finally, we have the tantalizing prospect of the support of robotic engineering to add to the skills of surgeons and interventional cardiologists, allowing the delivery of minimal access procedures.
We do robotically assisted heart surgery. The robot is a tool, and the question in each individual patient is the robot the right tool to assist the surgeon in doing the operation? Not everyone is a candidate for robotic surgery, but when we say you are a candidate, what we are saying is we believe we can do the same operation as safely and as effectively with the robot. It is used most frequently for mitral valve repair.
The robot enables us to get excellent visualization, to have very defined and fine technical movement in a small space.
The robot has two parts. One sits right next to the patient, and it's got 4 different arms. They're long tubes that go into the patient, into the side, through little puncture holes. And each one of these tubes holds an instrument or a camera. The surgeon is sitting down at a console that looks like a very elaborate video game. We get unparalleled visualization inside the heart.
It is a far less traumatic experience. We're essentially taking a large incision that divides the entire breastbone, we're moving it to the right where you're going in between the ribs and really having only about a 3 to 4 centimeter main incision and then incisions for the various working ports. So cosmetically, it's a huge improvement, but then also in terms of chest stability and shoulder girdle stability post-operatively, it's a huge benefit.
With this very small opening that we use for robotic, the bleeding is less, the pain is less, they can come out of the intensive care unit quicker, and they have a shorter hospital stay and a much quicker recovery. There are no substitute for experience. So you have to have experience in both robotic surgery and mitral valve reconstructions.
So we'll pause the video there and we'll now go back to the final concluding slide. Thanks, Christian, if we can just project that. So with renewed apologies for being a bit delayed, and I hope I haven't eaten too much into question time, but I am happy to stay on for as long as you would like me to. I hope that we've demonstrated that COVID and cardiovascular disease together represent a perfect storm with consequences that are going to extend well beyond 2021. We've emphasized that prevention is better than cure, and that currently identifying individuals at risk is an imprecise science. And finally, I hope that we've given you a tantalizing view of what we are achieving at the moment and what we aim to achieve in the future of cardiovascular healthcare. Thanks for listening.
Professor Prendergast, thank you so much for getting to the webinar and spending time with us. Do you have a few minutes for questions? You said you were okay.
Absolutely. I've got fantastic. 10-15 minutes, no problem.
Fantastic, thank you so much. I suppose if I kick off the first question, then you're absolutely right, a tantalizing view to the future. Do you foresee a time when perhaps all cardiac surgery is done robotically?
I think we do see a time when that will come. I mean, clearly there's a new learning curve associated with any technology, and robotic technology is no different from that. I think that this is now rapidly becoming the norm in more advanced healthcare economies such as the US and Germany, and the availability of these technologies at the major centers is becoming habitual. We haven't arrived at that point yet in the UK. There are robots available for prostate surgery and some forms of gallbladder surgery, but we have yet to deliver that in cardiovascular healthcare. And we hope to see that in London within the next year or two.
Fantastic. I guess we did some polls earlier on, and one of the questions we asked was, do we think robotics will bring down the cost of treatment? And certainly the people who we polled on the webinar today thought no, it'll actually do the reverse, but that's in the short term. Do you think in the longer term it will reduce costs?
Well, planning healthcare economy is always difficult because traditionally we focused on the cost of the procedure and the cost of the devices. And we don't think very much about the length of stay in the hospital. We don't think about the consumption of resources while you're in the hospital. and we don't think about the rapidity of recovery and return to normal activity, including the workplace. If you take a longer view, a broader view of how much this all costs and how much it costs employers to have their employees absent from the office or from the shop floor, then clearly those costs very quickly become recouped. So investment in technology up front is important, A, because it rapidly cheapens the economy, it becomes easier to afford, and secondly, because it becomes overall more cost effective to apply these advanced technologies.
I think that's the way people should look at it. It's the longer term return to work and productivity that's associated with that actually provides a saving. Just another question that's coming on the genetic fingerprinting side. Again, a view to the future that 10, 20 years ago we all thought was science fiction. How far away is that from kind of being able to predict chances of having cardiac issues?
So you can now get your DNA fingerprints very readily. That technology exists. It's quite well advanced in the US. You can, I believe, you can even go on Google and get your personal DNA fingerprint matched. What we haven't worked out is how we use that information at population or individual level. So some things have been quite well described, as I indicated, for example, risk of certain cancers, including breast cancer.
Yeah.
So if there is a family history of breast cancer, you can work out whether you are at risk as a particular female. For other cancers, the technology is also developing, but the problem we have with heart disease is that the fingerprints aren't so specific. It's almost like a combination of 12 fingerprints, and how you merge those different fingerprints and how you use the information more precisely has yet to be determined. So I think it remains a little bit space age, maybe within 5 or 10 years.
It's certainly exciting, although quite scary to know that you might be able to take a quick test and know your future medically. But then I guess you've got things to look out for. And one question that has came in is, taking it back down to a more realistic kind of today piece, what should we be looking for in terms of early signs of issues within our friends and colleagues? What are the danger signs of cardiac issues?
Well, at common sense level, the first person to watch out for is the person who neglects their health. And that may be very obvious to those around them, people who are inactive, overweight, smoking, drinking heavily. We all recognize these individuals as colleagues, but we're often not very good at supporting them and identifying issues and helping them. The second point is that it's human nature to ignore symptoms, and we're all guilty of that. In fact, doctors are probably the worst, to be absolutely honest with you. But ascribing symptoms to being out of condition or getting a bit older or not being as fit as I used to be is a very common mistake. And very frequently, when we meet patients for the first time, we look back and we recognize that the symptoms that were building up to a heart attack or a new diagnosis of heart failure were actually evident a year ago. And they've been neglected and overlooked by the patient and often by their carers as well. So the awareness is everything, and supporting the patients at risk at an everyday colleague and friend level.
Yeah, and I think your case study there of the relatively fit and healthy 66 years probably is kind of ringing alarm bells. A lot of people thinking, just because you are fit and healthy doesn't mean you should ignore symptoms and prescribe it to something else, a bit of tiredness, whatever it might be. I think whilst you've given us a very kind offer to continue on, we are running over, and I think we'll probably say we'll kind of answer any other questions that come in remotely and get back to everyone. I think we can all agree that there's an awful lot we can do to look after our hearts, and you provided us with a fascinating insight today. Before we all go, we were circulating a copy of the webinar today, plus a write-up in about a week's time, and there'll be a short survey when you log out, and if you could just take a second to do that, that'd be really helpful for us to plan future surveys. I think finally for me, it's just to say a big thank you to the audience for spending the time today, but primarily to you for taking time for what is clearly a very busy schedule, and for Christian as well for stepping in so well at the very last moment. Thank you so much for that fascinating insight into that really important subject. That's it from us. Take care and stay safe, and thank you again very much.
Thank you.